Hi, everybody. My name is Christopher Szabo. I'm an Associate Professor of Anesthesia at Yale University in Connecticut. I happen to work clinically in the CT ICU at Yale, the vascular ICU, and then the surgical ICU at the VA hospital in Connecticut. Thank you for the opportunity to talk today. I'll be giving a brief kind of cursory introduction on intraoperative management of the patient with severe pulmonary hypertension for non-cardiac surgery. Disclosures, I have no relevant disclosures. I do receive some honorarium from UpToDate, not related to this at all, is in the preoperative fasting guidelines or preoperative fasting topic for UpToDate. However, I do have some biases how I approach this cohort of patients and how I manage them intraoperatively, and I'll share that with you today as well. I think it's important to have certain core concepts to bring back as learning points at the end. First, as you probably are aware, the induction of anesthesia for a patient with PH is extremely high risk with hemodynamic instability and potential cardiac arrest. And we'll go through that a little bit. And I really like a mental model that came out in critical care medicine and anesthesia critical care about thinking patients with severe PH as having a physiological difficult airway. And we'll kind of go through a schematic later in the talk about it. I also think it's extremely important when you're planning for the intraoperative care or perioperative care that you need multidisciplinary planning. We know that patients with PH have excessive morbidity and mortality when they undergo non-cardiac surgery, and I'll go into a little bit more depth. I put this slide here for two reasons. As I mentioned earlier, we'll be talking about one aspect of PH care, those with undergoing non-cardiac surgery, but the nuances in this cohort of patients is extremely vast and deep, and we're continuing to learn. So this is kind of, again, a more cursory discussion. I won't talk about patients with severe PH who are undergoing cardiac surgery, so those who have maybe type 4 pulmonary hypertension related to chronic thromboembolic disease, or patients undergoing surgery for valvular disease. I also will kind of avoid patients who have had or undergoing transplant, either heart, lung, combined heart, lung, liver, etc. I think to start, it's important to kind of talk about the morbidity for patients with PH undergoing non-cardiac surgery. And this is a little bit older study from 2005 in Jack, but this is a retrospective study analysis of patients who underwent non-cardiac surgery with general anesthesia. This was again over a 12-year period, so from the mid-90s to early 2000s. The authors had a database of PH patients of just under 1,300, and of those 1,300, 145 patients had precapillary PH. So we'll talk about the different groupings, but groups 1, 3, or 4, and their baseline RV systolic pressures were around 68, which was measured by echocardiography. In table 2, we kind of have the incidence in early morbidity in these patients, and you see the N of 145. So out of that 1,300, 145 were included for analysis, and you can see kind of different types of morbidity with not surprising respiratory failure as a highest frequency morbidity in these patients. And then they kind of stratified these analyze these with certain operative characteristics for morbidity and length of stay. And you can see that high-risk surgery, the duration of anesthesia, and the intraoperative will say vasopressors, but they specifically looked at dopamine and epinephrine as kind of having elevated perioperative morbidity. This again is same study and looking at independent predictors using a multivariate logistic regression model. So in table 6, you kind of have these four, again, duration of anesthesia over 3 hours, was an independent predictor for morbidity. And then length of stay, you can see patients who had, again, a longer case, intraoperative use, they used dopamine in this study or in this cohort in an intermediate high-risk surgery. So we know that they're at high risk for length of stay, morbidity. I really like this review article on the evaluation and management of PH patients for non-cardiac surgery. It came out a couple years ago. We're going to talk a little bit about different classifications. So we have our clinical classifications, which I did not put on this slide here, and we have our hemodynamic classifications, which are in that chart there. So I'm sure many of you are familiar, or all of you are familiar with the World Symposium classifications for PH, the WSPH, and that's our 5 classes, right, or 5 groups. Group 1 being our pulmonary arterial hypertension group, which is generally considered idiopathic or drug-induced or connective tissue disorders related. Type 2 PH, which is related to left heart disease, the most common form of pulmonary hypertension. Group 3 PH, related to lung disease or chronic hypoxemia. So you're thinking of the patients with ILD or COPD. Type 4 is very specific to patients with CTEPH, so chronic thromboembolic pulmonary hypertension. And then group 5, which is our unclear or multifactorial grouping. I kind of consider that the catch-all. And then also, I think mentally, as a nice way to classify them is the hemodynamic classification you'll hear about. So specifically precapillary pH with those hemodynamic markers in that first row. Isolated postcapillary pH, which is 2 and 5, groups 2 and 5 that we just discussed, with those hemodynamic classifications. And then they describe in this article combined precapillary and postcapillary, sometimes known as mixed pH. I'm not going to talk a little bit about exercise pH. It's important for me to understand when I'm planning an anesthetic in this patient population, I want to know their World Symposium group diagnosis and also kind of their hemodynamic classification. This is the same review article looking at the management. And again, we're going to kind of focus on the intraoperative management moving forward, and we're going to use a case discussion to help kind of go through it. But I really want to highlight, before coming to the OR, it's important to have that multidisciplinary team to assess the patient. So that includes us in the anesthetic world, or anesthetist world, the surgical team, pulmonary, and cardiology, right? One reason that we want all these teams on board is to evaluate a patient's functional status, particularly of the cardiorespiratory system, to look at kind of to risk stratify them and hopefully mitigate complications. And then are there any opportunities that we can intervene on before they go to surgery? I really think this slide is a great pictorial of the perioperative concerns, and it kind of moves into this spiral of patients with PH and why they decompensate in a perioperative setting, in particular with right heart failure. And there's this idea of how well is their coupling, so how efficient is the RV as you're going into the intraoperative phase. And you see all those kind of red hemodynamic markers that put a patient at risk for what's called decoupling between the RV and PA. And then that blue arrow that kind of envelops it all, you have specific PAH treatments that might help you decrease your risk of either vast hemodynamic instability or potentially cardiac arrest. Some risk factors that we'll go into a little bit more are preoperative right atrial pressure of over 7, a low pre-op 6-minute walk test or a decreased functional 6-minute walk test, and perioperative vasopressor use. So let's get into a case. This is an actual one that I had a couple years ago prior to all these guidelines and discussions coming out. He was 79. He had idiopathic pulmonary fibrosis. He was on 2 liters of nasal cannula chronically at home. obviously, pulmonary hypertension. He had groups 2 and 3, one from the IPF and one from diastolic heart failure and valvular disease. He had aortic stenosis, had a TAVR done when he was a couple years prior, and post-operatively developed a AV block and required a dual chamber pacemaker, CKD, renal cell cancer, and cervical stenosis. And his presenting surgery was due to a oral cancer at the base of the tongue. So he was getting a glossectomy, a possible mandibulectomy, and a flap. As you can see, there's his other prior surgeries, and those are his preoperative medications. I'm going to highlight the, I might not pronounce it right, but the nintedanib, which is OFEV, which is for his IPF. It's an antifibrotic or lowering fibrotic state from his IPF. Treprostinil, which he was using as an inhaler, also known as Tyvaso, and tadalafil. He happened to also be on Ozempic or semaglutide for his diabetes. So we're going to talk a little bit about perioperative monitoring, the role of echo, right? So important data that we would like to have as we're planning our anesthetic would be certain echocardiographic measurements. I think, as you can see there's a few things I bring out, but I really want to talk about this TAPC to PASP ratio. So tricuspid annular planar systolic excursion, an echocardiographic marker, sometimes associated with RV function, and a pulmonary artery systolic pressure. And that ratio is another measure of kind of RV PA coupling or RV efficiency. And there are certain cutoffs that we worry about for perioperative concerns. And it actually is, there's a prognostic aspect to this TAPC to PASP ratio. And so when it is higher, so the number to remember is over 0.32, patients with severe PH are kind of considered a normal risk for perioperative complications. The lower that ratio, and really less than 0.18, puts you at high risk for perioperative mortality specifically. This is from the European Society. There was a retrospective study that looked at just under 700 patients who had PAH, and when you had targeted therapies and an improvement in that ratio, that TAPC to PASP ratio, they were able to decrease their mortality risk. They also showed some hemodynamic improvement as well. So something to think about as you're planning and optimizing a patient. Right? Other things I think about besides that would be, what is their ventricular function, biventricular function? What are your Doppler estimates if you have valvular disease? Can you get other measurements from there? And any concerns from some type of shunt. This is our patient's PFTs. I am going to highlight his diffusing capacity, which is extremely low. I'm looking at that DLCO corrected for hemoglobin, right? And it is almost unbelievable where he has a 3% predicted, right? We know that less than 30 is extremely high risk for perioperative outcomes. It's almost unbelievable that it's saying 3%, but that's what kind of they were able to measure from him. And he also had, his other parameters consistent with restrictive disease, no obstructive disease. I think it's important not to just know the echo report, but also look at the images themselves. So in this view, we have our subcostal window, and you can see kind of his pacer going through the tricuspid valve there. You do see some movement of the tricuspid valve. Right. And then I don't have unfortunately, the parasternal short axis, but I have an apical 4. And this is kind of the right ventricle view, which is a little bit more concerning, right? It looks dilated. The TAPSE function does not look as robust as it did in the subcostal view, and that's why it's important to kind of take all the views into account. And on the right, it's kind of a more left-sided view. Other kind of qualitative measurements, you could see that the RV looks at least as big as the LV, from what we can tell, although it's not perfect. This is the report. So our patient's LV EF was 40 to 45%. When they had the peristernal short axis, they saw that the septum was flattened in both systole and diastole, indicating pressure and volume overload. As you could see in the pictures as well, his apex was akinetic with some hypokinesis in the LV. He did have the bioprosthetic AVR that was working well with moderate TR by color and by pulse wave Doppler. And so after you get all those, we were able to do some measurements here, right? And his right atrial pressure was 8. He had a TAPSE that was abnormal at 1.4 centimeters, and he had an extremely low measurement of that TAPSE to PASP that would put him in a high risk for mortality. Right. Other than that TAPSE to PASP, other factors that again we worry about would be a right atrial surface area of right atrial area over 27 square millimeters, any presence of effusion, and any other, again, valvular disease that may have not been picked up after he had his TAVR a couple years ago. As part of the multidisciplinary planning, he also had a right heart cath. And again, here are some of the measurements they were able to do. I highlight that his wedge is 7, mean of 4. Right atrial pressure was 4, so it seems like he was well optimized before. His PVR was extremely high, over on the right of about just under 14 Wood units, and the transpulmonary gradient, which is our mean minus our wedge of 48, so really consistent with precapillary pulmonary hypertension in that hemodynamic classification. So let's move into kind of the intraoperative goals. As you can see here, I'm sorry that the box moved a little bit. We really want to kind of look at some of these nuanced hemodynamic measurements, like so a cardiac index of over 2.2, if you have some degree to measure that, maintaining sinus rhythm, or in his case, AV synchrony with his dual chamber pacemaker, not having an elevated right atrial pressure, avoiding, I think, the big three that we think about: hypoxia, acidosis, and pain and shivering, and avoiding high airway pressures when you're doing general anesthesia. Okay. So some of these things require further monitoring. And so you can talk about PA catheters, intraoperative TEE. Would you like both of them? Do you think one is sufficient? Would you not like either of them? You don't think it's necessary from what you get from your preoperative data? A lot of this is based on expert opinion and not a lot of evidence. As we all know, there's no defining evidence that a specific monitor influences someone's morbidity and mortality. I think in looking at TE, this article from Hoffer et al. Looked at pre-op diagnoses in TOE, so transesophageal echo, and therapeutic consequences, right? But what can TE assist me in, right? It can help me assess why someone might be hypotensive intraoperatively, looking at maybe dynamic changes in cardiac function or valvular function, fluid responsiveness, particularly through maybe shooting a LVOT VTI. Or is there something concerning from the case that they developed a thrombus or something, particularly in a patient who has cancer, right? Interestingly, in this article by Hoffer, right, they were able to find new TE findings that did not exist in the preoperative evaluation. So what that resulted in that there was a change in medication therapy in about just under 50% of patients, and changes in fluid therapy in about 1 in 4 patients. So not insignificant in a cohort that's high risk for perioperative complications. All right. So how about a PA catheter? Right. Also can give us real-time continuous data as well, particularly if a patient who is hypotensive or concerns for shock. In these patients with the amount of tricuspid regurgitation, thermal dilution calculations may not be as accurate, but mixed venous can still be helpful, right? There's a lot of, I think, strong opinions as to the intraoperative use of a PA catheter, right? There are some that believe it's absolutely necessary, and continuous monitoring helps guide therapy. The insertion, though, can be fraught with complications. We all know that. Arrhythmias, things that we would like to avoid. This cohort usually over time has PA dilation, and they're at increased risk of either alveolar hemorrhage or PA rupture when placing the PA catheter. So you really have to do a close kind of risk-benefit analysis on your patient to place it. I think, interestingly, another study compared PA catheter and intraoperative TT simultaneously, and patients who already had a PA catheter, the TE gave other findings that the anesthetist acted on, even with a PA catheter present. So maybe that could be from training, or that people are more comfortable using a TEE for intraoperative therapy. I do want to bring this next article out. It does talk about cardiac surgery, but the group up in Montreal, led by Dr. Denault, I think is very interesting. Right, there's more and more PA catheters that have RV pressure monitoring, and that's really one of the features that we really care about, right? We want to know RV and diastolic pressure for RV preload to make assumptions about volume responsiveness, correct? And he has a nice little algorithm that you can think about in looking at your RV pressure waveform to help you. And I have 2 different waveforms here in A and B. And I'm going to kind of go through that algorithm with you, right? And we're going to assume a couple things: that the patient is the right size, and that the catheter is in the appropriate position. So after you get through there, you have your PRV, so your RV pressure, in your PPA, so systolic pressure. And you're going to be looking at the waveform in your diastolic waveform. So where those numbers are 10 millimeters of mercury and 11 millimeters of mercury in A, versus 4 millimeters of mercury versus 14 millimeters of mercury in B. So to go back, A, to describe that a little bit more, the PA pressure waveform is in yellow, the RV pressure waveform is in green. And so they're kind of showing you the difference in these RV and diastolic deltas, basically. And sometimes in that B, that's noted as the square root sign, which is a pattern that you see in RV diastolic dysfunction or RV failure. So that's as opposed to A, where you see kind of a RV and diastolic pressure that is not having that large discrepancy, and it's actually very close to the PA diastolic pressure. So something interesting. Again, it's specific for cardiac surgery, but there might be an opportunity to look at more deeply in non-cardiac surgery as well. So going back to our patient, we're getting ready to bring them into the OR for anesthesia. And I talked about this as kind of a mental model. I really like the concept of a physiologic difficult airway. It came out a couple of years ago in the anesthesia critical care literature. And you can see kind of different pathophysiologic alterations. I'm going to focus on RV dysfunction in patients with PH, right? And we talk a lot about this paper talks a lot about ICU patients and emergency room patients, but I think it's useful to think about this in the intraoperative and perioperative setting as well, right? And they do this risk for complications during induction of anesthesia, transitioning to positive pressure, and removing kind of sympathetic stimulation with induction agents itself. There's a different kind of preparation, but I think what we're really trying to look at here is to optimize our RV function and to minimize hemodynamic collapse when these transitions happen. And I think it's important for me to show you how that works clinically, because I learned from it. This came out after this case. So this is that same patient that I did back in 2022. We decided to do a pre-induction A-line, which you see there in those kind of blue markers here. This is our EMR here at Yale, and his heart rate here in this little pink dots. And what you see where the red lines are is when we pushed rocuronium and went from spontaneously ventilating to positive pressure. And you can see this big drop in his systolic blood pressure. We also induced with inhaled nitric oxide to help with as a pulmonary vasodilator in the periop and the induction period. And despite kind of all that, I definitely had an opportunity to probably improve. Systolic dropped extremely low, as you see here by the nadir. We had a brief period of cardiac arrest and ACLS, which has compressions, with ROSC. And then kind of right afterwards, we still had some swings in blood pressure here. And then we eventually settled out on a cocktail of dobutamine or epi for hemodynamic support. And since we couldn't use paralysis long-term, we converted him to remifentanil for neuromonitoring intraoperatively. And they were doing a neck dissection. Again, really the quick drop over a couple minutes, over a minute or so here, down to a cardiac arrest. So not probably my best anesthetic, I'll be honest, despite talking about this today, but a very important learning point. He did stabilize out. We had a discussion after the arrest about should we continue the case or not continue the case. And after discussion with the surgical team, we felt that this was his best chance to have curable disease, and it still seemed to be pretty localized, and so we proceeded with the surgery itself. At the end of the case, we kind of were looking at kind of acidosis, oxygenation, ventilation, and any other concerns, and he actually got extubated at the end. Went to the ICU. So that was an interesting, very important learning for me, honestly. We were not able to put a TEE or a SWAN in that specific case, and that's the reason I picked it, was because where they were operating. So intraorally and in the neck precluded a TEE, and they had prepped the chest for a potential flap, so we couldn't do a surface TTE during the case. But aside from that, there's other considerations and other anesthetics that we can think about depending on the type of surgery needed, right? There are concerns that patients who have PH or PAH are anticoagulated. We know that there's changes depending on the surgical technique and in specific pneumoperitoneum, or how we're managing the ventilator, as well as positional changes in surgery. One thing that I would highlight from our other anesthetic options is that when we do choose to go down the intubation and airway management standpoint, is that we're able to control hypercarbia, acidosis, and oxygenation, which is an advantage, with the disadvantage of kind of what I showed you in that case of these hemodynamic changes, particularly when changing from spontaneous ventilation to positive pressure ventilation, blunting of the sympathetics with induction agents, and those concerns. Regional techniques could be great in the patients and keep them spontaneously ventilating. You just have to kind of take into account if they are in the anticoagulation, how are you going to manage that in the perioperative period. I want to take a few minutes to talk about neuraxial techniques. I'd say in general the consensus is that an epidural would be preferential to a spinal. to avoid bolus dosing of a local anesthetic and causing that maybe potential extreme vasodilation and dropping the coronary perfusion or myocardial perfusion. So maybe less effects with an epidural from a hemodynamic standpoint than with a spinal. And the last thing I wanted to show you is from Dr. Hirt, who was at Cornell. Kind of what happens to your PA pressure. This is prior to RV pressure monitoring that he did. But PA pressure under pneumoperitoneum. And as you see, x-axis is time, and you have those different curves, and you can see your kind of PA pressures start climbing and your PA blood flow decreasing with pneumoperitoneum. And yes, there are ways that you can mitigate that with either slow insufflation or lower insufflation pressures, but there are real hemodynamic changes that happen during this period as well. And so we generally recommend that we would favor open surgical approaches as opposed to laparoscopic surgery. And then at the end of many of these cases with severe PH, it's very important to have very close monitoring due to those perioperative concerns and perioperative complications. The timing of it or the length of the ICU stay or a closer monitoring stay would probably depend on the degree of surgical trauma or the surgery itself. But generally you're thinking at least 24 hours to a number of days depending on the intervention or the type of surgery. And as they continue to improve, they should hopefully get back to their preoperative state and move through your hospital and hopefully have stabilized to a preoperative level. It is 30 minutes. I don't want to take any more time. Again, I appreciate the opportunity to speak today. Those are my 2 emails. I checked them both. If you have any questions, I'd be happy to answer them. Please feel free to reach out. I look forward to working with some of you in the future. Thank you very much.